Good morning. Over the next 15 to 20 minutes, we're going to talk about something that touches almost every patient you will ever take care of: patient blood management, or PBM. Before I start, do a quick thought experiment. Think of the last three patients you anesthetized for a major operation. How many of you checked a hemoglobin the night prior to surgery, saw that it was a little low, and thought, fine, we'll just transfuse if it comes to it? Hold that patient in your mind. By the end of this talk, I want you to think about that decision differently. Our title slide already gives you the definition we'll build on. PBM is a patient-centered standard of care, managing and preserving the patient's own blood. Notice the phrasing: not a program to reduce transfusions, not a blood bank policy. A standard of care centered on the patient. That distinction is going to matter for everything that follows. So, four objectives, and they build on one another. First, recognize the burden, the true global scale of anemia, iron deficiency, blood loss, and coagulopathy, and what that means for the patient on your OR table. Second, understand transfusion risk. We need to unlearn the reflex that a unit of blood is a free, neutral intervention. It isn't. The evidence shows an independent, dose-dependent effect of allogenic transfusion on perioperative outcomes. Third, the principles of PBM, a proper definition and its three pillars, which give us a framework we can actually use at the bedside. And fourth, the part that matters most for us: how to apply PBM locally using a practical, adaptable, bundles approach. Let's start with the scale of the problem. These numbers are genuinely staggering, and I'd encourage you to sit with them. Globally, approximately 2.9 billion people live with anemia. Of those, 1.2 to 1.5 billion have iron deficiency anemia specifically, the single most correctable cause of anemia on the planet. Over 600 million people have chronic or acute blood loss or a bleeding disorder. And here is the number that should hit closest to home for us anesthesiologists. Up to 75% of surgical patients are anemic before they even reach the operating room. Three quarters. Think about next week's pre-op clinic. It's not a trivial condition to carry either. Anemia alone accounts for 8.8% of all years lived with disability across every condition worldwide. A bigger burden than most diseases we spend far more time studying. And in the ICU, hospital-acquired anemia, the anemia we cause through repeated phlebotomy and critical illness, reaches up to 100% of patients who stay beyond 7 days. In a very real sense, we are bleeding our patients dry, one blood gas syringe at a time. Anemia, blood loss, and coagulopathy together form one of the world's largest yet most under-recognized public health burdens. Why does this matter clinically beyond the epidemiology? On the left, independent risk factors. Preoperative anemia isn't just a lab value to fixed on the night prior to surgery. It independently predicts substantially higher postoperative morbidity and mortality. It increases the length of stay, readmission, and costs. Blood loss and coagulopathy, quite separately, independently raise morbidity, mortality, and ICU stay. And these effects span the entire lifetime. Neonates, children, pregnant women, the elderly. Nobody is exempt. On the right, look at the breadth of harm. it isn't only mortality. There's a real symptom burden, cognitive dysfunction, headache, breathlessness, fatigue, depression, even restless leg syndrome. There's obstetric and neonatal risk across the entire peripartum period. And here is a statistic worth committing to memory, because it's the kind that changes practice. Preoperative anemia, even mild, independently increases 30-day mortality with an odds ratio of 1.42 and a composite morbidity with an odds ratio of 1.35 after major non-cardiac surgery. Mild anemia, not severe, mild. That's the anemia we see a lot in pre-op, and sometimes we wave straight through to the OR. We should challenge the idea that blood is a neutral rescue therapy. Sometimes we or our colleagues from other specialties will say that if hemoglobin is low, we'll just transfuse pre-op. The evidence says otherwise. After risk adjustment, allogenic transfusion is independently associated in a dose-dependent manner with increased morbidity, mortality, and length of stay. And critically, this isn't only observational data. Randomized trials show no benefit and sometimes harm from liberal transfusion. Why? Three broad reasons. First, known and emerging hazards: transfusion, transmitted infection, and transfusion reactions. Trally and TACO and simple human error all remain real risks, even in modern blood banking. Second, immunomodulation and the storage lesion. Biological changes in stored red cells and in the recipient's immune system considered key mechanisms behind these adverse outcomes. And third, don't forget the systems level reality. Blood is expensive, sometimes unavailable, and a strain on health systems. Speaking from my experience in public health, the community blood donation drives follow the local government unit budgetary cycle. The funds start to run low on November and usually won't be replenished until February or March of the incoming year. Hence, this period is known as the lean months in the availability of blood province-wide. We have a triad of independent risk factors for adverse outcomes: anemia, blood loss, and bleeding, and transfusion. Independent is the operative word. Each one, alone, predicts worse outcomes regardless of the other two. Anemia is highly prevalent, frequently untreated, and an independent predictor of morbidity and mortality, even when mild, as we just saw. Blood loss and bleeding are surgical, procedural, and iatrogenic. And yes, that includes the cumulative phlebotomy losses. And transfusion itself is independently associated with organ injury, infection, prolonged stay, and mortality in a dose-dependent fashion. Here's the good part. All three corners of this triangle are modifiable, and all three are exactly what the three pillars of PBM are built to address. This question deserves its own moment. It's the kind of thing that gets posed as a trick question in oral exams, and for good reason. What is really dangerous, anemia or transfusion? Paradoxically, both anemia and transfusion are independently associated with organ injury and increased morbidity across a wide span of disease states. There is no safe default here, and that's precisely why PBM doesn't simply ask you to swap transfusion for tolerated anemia. It asks you to treat the anemia, minimize the blood loss, and transfuse only when it's truly indicated. Let's define PBM properly, because misconceptions about this term are everywhere. The globally accepted definition, from Shander and colleagues, adopted into WHO guidance in 2024, states that PBM is a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving the patient's own blood, while promoting patient safety and empowerment. Notice three things packed into that sentence. It is focused on the patient. Attention shifts from the blood product to the person in front of you, not one pathology or one procedure. It's a whole team effort. The entire healthcare team coordinates across the continuum of care, from the pre-op clinic to the surgeon, to you, and to the ward nurse. It treats blood as a vital liquid organ, managed with the same respect we'd give the heart or the kidneys, not ordered up as a commodity from the blood bank. PBM is not simply optimal blood use or restrictive transfusion. Those have a narrower focus on the transfusion decision alone. It is not a program whose goal is merely to reduce transfusion numbers, and that would make it a cost-cutting exercise, not patient care. And it is not a reason to withhold IV iron out of some outdated fear. Modern preparations are safe and effective, and underusing them is itself a PBM failure. PBM is preemptive. It values the patient's own blood long before transfusion is ever on the table. It's a broad clinical framework spanning the whole continuum of care, and it's evidence, economics, and ethics driven. Fewer transfusions follow as a result, but they are merely the byproduct, not the goal. The essential shift, and I want you to remember this phrase, is from the blood product to the patient. This is the operational core of PBM. Pillar 1. Detect and manage anemia and iron deficiency. Routine detection, evaluation, and cause-specific diagnosis, not just noting a low hemoglobin and moving on. But instead, we should ask why. Treat the underlying cause. Use pharmacological agents and nutritional supplements. Iron being the obvious example. Pillar 2. Minimize blood loss and optimize coagulation. Identify and manage bleeding risk in a timely way. A pre-op job as much as an intra-op one. Use anesthetic, hemostatic, and surgical blood conservation measures. Manage any coagulopathy that results in bleeding, rather than simply replacing what's lost. Pillar 3. Harness the physiological tolerance of anemia. This one is very much ours. Leverage the patient's own tolerance of anemia. Optimize ventilation, oxygenation, and cardiac output. Minimize oxygen demand. Temperature control, sedation, analgesia, everything that drives up metabolic rate. Get comfortable with these three pillars. Every PBM intervention you will ever apply maps onto one of these. The three pillars become truly useful once you cross them with time, pre-op, intra-op, post-op, giving you this 9-field matrix. I won't read every cell, but notice the pattern. Preoperatively, under Pillar 1, there's a line worth memorizing. Anemia can be a contraindication for elective surgery. Intraoperatively, under Pillar 2, you'll recognize your own toolkit. Meticulous hemostasis, blood-sparing surgical devices, anesthetic blood-conserving strategies, autologous options, normothemia, hemostatic agents. And under Pillar 3, intraoperatively, it's squarely our domain. Optimize cardiac output, optimize ventilation and oxygenation. The point isn't to memorize every cell. It's to internalize that PBM is not a single pre-op checkbox. It's a continuous thread, through every phase of care you're responsible for. This is, in the words of the Matrix itself, a perioperative, multidisciplinary, multimodal, patient-specific team approach. No single specialty owns it. So, how do we make this operational rather than just an inspiring framework? This is the bundles approach, sometimes called the ABC toolbox. The idea is simple. For each phase of care, select a bundle of measures mapped to each pillar. Preoperatively, detect and treat anemia and iron deficiency early. Minimize iatrogenic phlebotomy loss. Assess and optimize physiological reserve. Intraoperatively, time surgery to an optimized hemoglobin. Practice meticulous hemostasis with cell salvage and antifibrinolytics. Optimize oxygenation and cardiac output. Postoperatively, continue iron or anemia therapy. Maintain vigilant monitoring to avoid rebleeding and support recovery with restricted transfusion thresholds. This bundles approach is what makes PBM operational and repeatable, rather than something that depends on one enthusiastic consultant remembering to mention it. It's checklist culture applied to blood, in the same way that we have applied checklist culture to operating room setups and to the difficult airway. This leads directly to a concrete, actionable recommendation from the Choosing Wisely campaign and the Society for the Advancement of Blood Management. Don't proceed with elective surgery in patients with properly diagnosed and correctable anemia until the anemia has been appropriately treated. Does any of this actually work? Or is it just a nice framework on paper? The data says yes, convincingly. A compiled dataset of comprehensive blood conservation and PBM programs shows that transfusion was reduced by 10 to 95%, mortality reduced by 68%, average length of stay reduced by 16 to 33%, reoperation reduced by 43%, readmissions reduced by 43%, complications, composite morbidity reduced up to 41%, infection rate reduced up to 80%, and costs were reduced by 84%. For a single rigorous anchor number, look at the Althoff meta-analysis in 2019. 17 studies, 235,779 surgical patients. Implementation of a multimodal, three-pillar PBM program was associated with a 39% reduction in transfusion rate and a reduction of 0.43 RBC units per patient, reduced hospital length of stay, and a 20% reduction in total complications, and an 11% reduction in mortality. I want to underline the line at the bottom of this slide because it dismantles a false tension many of us assume exists. Improving patient outcomes and reducing costs are not competing goals here. PBM delivers both, and it frees blood for the patients who genuinely need it. This is not about rationing, it's about better medicine that happens to also be cheaper medicine. If a meta-analysis feels too abstract, let's ground this in a real, large-scale program. Western Australia ran a statewide PBM program across 4 hospitals, covering over 600,000 patients from 2008 to 2014. As blood use fell, outcomes improved, not despite reducing transfusion, but because of the comprehensive program built around it. Mortality fell 28%, infection fell 21%, MI and stroke fell 31%, length of stay fell 15%, red cell units used fell 41%. Cost savings were roughly $8.5 million in blood products alone, with an estimated $80 to $100 million saved once avoided transfusion and administration costs are included. Across programs more broadly, transfusion was down to 10 to 95%, mortality was down up to 68%, and complications down to 41%, with length of stay down to 16 to 33%. This is not a nice-to-have intervention for well-resourced academic centers. It has been done at a statewide scale and it paid for itself many times over. If the evidence is this strong, why isn't PBM already the universal standard everywhere? Three drivers should compel us to act: evidence, real-world data, RCTs, and meta-analysis consistently show improved outcomes. Stakeholders are alerted to act. Economics, cost-effective with near immediate return on investment. Stakeholders are enabled to act. Ethics, an obligation to adopt a proven model that benefits patients, society, and donors. Stakeholders are obligated to act. But real challenges remain: low awareness, deep, deeply ingrained transfusion culture, many of us picked up along the way, many desperate stakeholders with no single owner, gaps in care coordination, the need to restructure product-centered transfusion committees into patient-centered PBM committees, and an ongoing need for robust data on outcomes. Nothing on that list is insurmountable. Most of it starts with exactly what we're doing right now, building awareness one conversation at a time. So, four takeaways to close. Anemia is common and dangerous. Anemia and allogenic transfusion are independent risk factors for morbidity and mortality, not a lesser evil in the rescue therapy. PBM is patient-centered, a systematic, evidence-based approach to manage and preserve the patient's own blood. The focus is the patient, not the product. Get Pillar 1 right. Detecting and managing anemia and iron deficiency is the single highest yield step in everyday anesthetic practice. And it starts in the pre-op clinic, not the operating room. Implement in bundles. Use the PBM toolbox. Apply bundles across the whole continuum of care and make this the default, not the exception. So go back to that patient you thought of at the start of this talk, the one with the mildly low hemoglobin on the night prior to surgery. Was that really a same-day problem? Or was it a missed opportunity 3 weeks earlier in the outpatient pre-op clinic? Doctors, patient blood management is the new standard of care. Thank you.